physical therapy assistant school, and she works with me here in our Plainsboro facility. So we're going to demonstrate on Jen. So again, I tell a patient what we're going to do first, and I would demonstrate it on somebody else before I did it on it. Good idea. Okay. Slide back. So we sit in this long sitting position, and from the history, I gathered, is it when they turn to their right side of bed, or is it when they turn to their left side of bed? So if Jenna was to say, Mark, when I turn to my right side, I get dizzy. What I'm going to do is I'm actually going to test her other side first, and I'll tell you why in a second. So what we're going to do is, I'm going to turn her head, I'm going to come quickly off the edge of the table. Okay. And the key thing we tell our patient is to keep your eyes open, because we need to see that eye movement. So again. Okay, and we do both sides. So we just did the left side. We would do the right side again, Jenna. We're going to go to the right side now quickly. You want to relax the head. You want to keep the eyes open. And you're looking for that eye movement. So we do one side, we sit her up, then we do the other side. Now the reason I said that I would do, actually did her left side first, was because I think the right side is the active side. I can actually go right into the treatment when I do that second part of the test. So right now we're going to assume, again, her right side is the active side. So what we do is we always go down to the right side first, head back, eyes open. What we do is we stay in this position for 30 to 60 seconds. Okay? And what will happen is there'll be a period where there is no dizziness. There'll be a period where the dizziness comes on and we see the eye movement, and then it will subside within usually 30 to 60 seconds. That's position one. Position two is we rotate the head to the left side. Again, we're looking at the eyes. You may or may not get dizzy. We stay here for 30 to 60 seconds. The third position, we have the patient roll on the side. The nose is pointed towards the ground. Again, we tell the patient, you may or may not get dizzy in this position. We wait again 30 to 60 seconds for even if she's not dizzy to subside. And then the last position is just sitting up. And what we do is we just kind of keep the head down for about a minute. And we repeat that 2 to 3 times. And usually on the second or third trial, you'll get kind of less dizzy as you do it. And it's better to do more trials in one time than it is to just do once and then come in the next day and maybe do it again. So does anybody have any questions about the test or the treatment?
What do you do when the patient starts vomiting? Because that's what would happen to me.
Yeah, you know what? I've never had a patient vomit on me. It does come along with it. Again, the nausea and vomiting is not unusual. But again, this is really the only way to treat it. You can treat with meclizine or antivert, which are vestibular suppressants. But what that's going to do is just diminish the symptom. It's not going to treat the problem. So, you explain to the patient again, you're going to get dizzy, you may get nauseous, you may vomit. Yeah, obviously, if you're vomiting, it's going to throw a glitch into the actual treatment. But
and I have this, and it seems like I have an episode. It'll be a few weeks, and then it'll go into remission for maybe several months. Is that the crystal settling back in the right place? What's happening?
It may, but sometimes people live with it for years and they don't get it treated. So I've had patients I've treated that have had it for 10, 20 years, and it does come and go. I do think yes, it's mechanical. These crystals will come out of position. They may go back a little bit, but again, it's a very successful treatment. It obviously doesn't take too long, and and again, there's other conditions that cause dizziness and vertigo, so you just have to rule out those other conditions. But I understand, that's scary, and that's something to be concerned about. But we would just, hopefully, the more you did it, again, the less dizzy you would get. Luckily, I guess I haven't had to deal with that, but. So we give our patient instructions after the maneuver. We tell them, wait 10 to 15 minutes before you leave, because you may get these bursts of dizziness or spins. We advise them to sleep semi-recumbent for 2 nights, which is basically the position you see here, either in a recliner or with 2 or 3 pillows so you're elevated. We tell them to not lie. I don't know why I missed on this slide. You don't want to lie on the affected side. So if it's the right side, don't lie on your right side. Left side, don't lie on your left side. For 1 week, avoid things that provoke it. So if you're looking far up or looking far down, try to. Now you can't really walk around, like this all day, but try to avoid anything that would provoke it. I tell people to call me in a week. Sometimes I call my patient after a couple of days just to check in with them and see how they're doing. But most of the time that I've done this hundreds of times, it's one time. There's patients that have it in both ears. There's other things. So I do like to see the patient, in 1 month, basically to reassess them and see, did I miss something? Like, are they still dizzy? Because I don't want to just say bye and then you come back and you're dizzy a month later, because you might have something else that's causing the dizziness. And if I can't help you, I need to refer you to the right medical professional. So again, this procedure is effective in 80% or more of patients with BPPV. Okay, there is a home treatment. I don't know if you've tried the home treatment. So it's essentially the same as what we did. I'd say a couple of drawbacks to the home treatment are that, first of all, you can't see your eye movements, I find it maybe a little more successful to have a little more control of the neck movements. But again, this is for someone with left BPPV. As you see in the picture, you turn your head to the left, same thing. You go off. The pillow is kind of like the edge of the table, like I did with Jenna. Turn the head to the left, then the head turns to the right, then you roll on the right, and then you sit up. So it's the same exact thing, except the pillow, is preventing you from going into like any further movement. So it does work, it's effective, and it's another option. Another treatment that is out there that's not probably as, let's just say, like popular as the home epley is these Brandt Daroff exercises. And it's often used when you can't determine is it a right side or left side. You do these exercises 3 sets a day for 2 weeks, and they have a pretty good success rate as well. It takes 2 weeks, which is the drawback, but they are successful, so that's another option. Okay, so these are other common vestibular conditions, and we're going to talk about a number of them. BPPV, Meniere's, labyrinthitis, vestibular migraine, TIA, which is a small stroke, ototoxicity, which we talked about with the medications, and finally microvascular compromise. So again, we're going to repeat this. The most important question that I'm going to ask you, or your ENT or your doctor, whoever's doing this on you, is how long does your vertigo last? As you see here, BPPV is less than a minute. Meniere's can be hours. And I've evaluated probably a number of people that when they say a couple of other key characteristics, I'm like, okay, you may have this condition, you need to go see your doctor. Because I don't, I can do one part of the treatment, but there's other things that go along with that. Labyrinthitis can last for days. So if you tell me you've been dizzy for days, chances are you don't have BPPV. A TIA can last minutes. A migraine can last, again, hours. And microvascular compromise can be just instantaneous. And ototoxicity can also be instantaneous, or it can last, as it says here, forever. So let's go into, again, what I'm thinking about. I always think about when I'm treating my patient, whether it's for back pain or shoulder pain or knee pain, is there anything I'm missing? If I'm missing something, I'm not doing you justice, I'm not helping you. So we have to go through this process of differentially diagnosing the problem. And again, some things are treatable with PT, and some things you need to see your doctor, your ENT, or your neurologist. So Meniere's, vestibular neuritis, labyrinthitis, and post-traumatic vertigo I would recommend you see your ENT. You could see, PT could be a part of all of those in terms of doing vestibular rehabilitation, which involves certain exercises with head and eye movements. But again, you want to confirm what the diagnosis is first.
Considered post-traumatic.
That's after after trauma, like we talked about head injury or whiplash, something like that. So, neurological disorders, again, you want to see a neurologist. So migraine-associated dizziness, vertebro-basilar insufficiency, which is when the arteries in the neck, can get occluded. Demyelinating diseases such as like MS,